Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today we will be diving deeper into pediatric CNS tumors, starting with a discussion on medulloblastoma. We are starting with medulloblastoma because this is one of the most common malignant brain tumors of childhood. It accounts for about 20% of childhood brain cancers and about 40% of posterior fossa tumors. And then it accounts for about 5 to 10% of all CNS primary tumors. So I would definitely say this is the most common malignant brain tumor that we see in pediatric patients. There's about 500 children per year that are diagnosed with medulloblastoma, and the peak incidence tends to be between ages 5 to 9. There's also a slight peak around ages 20 to 24, and then it's fairly rare after the fourth decade, but ages 5 to 9 is typically the peak incidence of medulloblastoma. There are a few different genetic syndromes that are associated with medulloblastoma. So Gorlin syndrome, which also stands for nevoid basal cell carcinoma syndrome, results from a mutation in the PTCH1 gene, which regulates sonic hedgehog signaling. And we'll see that sonic hedgehog is an important molecular marker for medulloblastoma with prognostic implications. So Gorlin syndrome with a mutation in PTCH1, that is also associated with higher incidence of basal cell carcinoma, macrocephaly, and eye defects. Turco type 2, which is also FAP or familial adenomatous polyposis, that results from a mutation in the APC gene, which regulates Wnt signaling, and Wnt is another molecular marker for medulloblastoma that actually portends a very good prognosis. So FAP is associated with APC mutation, which regulates Wnt signaling. We know FAP hopefully very well from its increased predisposition for colorectal cancer, pigmented eye lesions, and skin and bone lesions. Other syndromes include Li-Fraumenti, which is a mutation in TP53, and then neurofibromatosis type 1, which is a mutation in NF1. So Gorlin's, FAP, Li-Fraumenti, neurofibromatosis type 1, these all are genetic syndromes that are also associated with medulloblastoma. I'm going to try to fit all of the background, staging, treatment paradigm, and then also the evidence just into one talk rather than splitting it up into an overview and evidence lecture like I sometimes do. Just for the sake of simplicity, trying to keep it all condensed into one talk. My goal is really to present kind of textbook information and some of the key studies, but not too many studies that just kind of help us to understand how medulloblastoma is treated. My goal with these talks is to hopefully get us all to a point where we're ready for board exams, for the clinical written boards, as well as the oral examination, and kind of focus on board-oriented learning. I did not train at a proton center, and while I did, have experience treating pediatric cancer patients, this is not something that I personally am going to be specializing in. So kind of a blanket statement for all pediatric cancers, those that have trained at kind of more intense pediatric centers, hopefully with proton centers, understand that there's a lot that goes into treating these kiddos, and they really deserve to be treated at high level centers. They're often treated treated as per either institutional protocol or ongoing COG protocols. So again, just as a kind of disclaimer, the goal of my talks is really to get us to a point where we are board ready. But in terms of clinical practice, my experience with pediatric patients is quite limited. So I definitely would defer to the pediatric cancer experts on actual treatment recommendations. My goal is really to sort of focus on the textbook information that comes up on tests. So let us get started with a little bit of background. Most commonly, medulloblastoma presents in the posterior fossa, and about 75% of the time it occurs in the midline vermis. So just to review, the skull is divided into the anterior, middle, and posterior fossa, and the posterior fossa is that inferior portion which contains the cerebellum, the brainstem, and the fourth ventricle. So everything that is sort of in color on the image on this page. The vermis is the midline portion of the cerebellum that's responsible for controlling balance and coordination, and it connects the right and left hemispheres of the cerebellum. So that is kind of what the vermis is. It's the midline portion of the cerebellum. So again, most of the time, medulloblastoma presents in the posterior fossa, and typically when it does, it's located in the midline vermis, so in the central portion of the cerebellum. About 75% of cases occur in the vermis. If medulloblastoma occurs in the hemispheres, it tends to be more associated with older age as well as desmoplastic histology. But younger patients tend to have kind of, again, midline vermis medulloblastoma. The boundaries of the posterior fossa are something that you should be familiar with, just because high-risk patients with medulloblastoma actually get a posterior fossa boost. So we're actually boosting the entire posterior fossa for these patients with radiation. So the anterior border of the posterior fossa is the clivus and the posterior clinoid. Posteriorly, it's the calvarium. Superiorly, it's the tentorium cerebellum. Inferiorly, the occipital bone. And then laterally, it's just the temporal, parietal, and occipital bones. So kind of posteriorly and laterally, it's the skull that surrounds the posterior fossa. And then superiorly, it's that tentorium cerebellum. A little bit of pathophysiology. So medulloblastoma is one of the small round blue cell tumors, and there's a few different mnemonics out there to remember the different histologies of small round blue cell tumors. Mrs. Leap, lemons, learn to swim are some of them. But many of the pediatric tumors that we talk about, including medulloblastoma, Ewing sarcoma, neuroblastoma, and also alveolar rhabdomyosarcoma, these are some small round blue cell tumors. And medulloblastoma, of course, is one of them. So medulloblastomas used to be classified as PNETs, which are primitive neuroectodermal tumors. But in 2016, there was a WHO update, and they changed the classification of these embryonal tumors so that they are now known as embryonal tumors with multi-layered rosettes. And sure enough, if you recall from medical school, one of the classic histologic findings in medulloblastoma are these Homer-Wright rosettes. So that means that these are tumor cells that are concentrically arranged around a lumen that contains neuropil. So neuropil is unmyelinated axons, dendrites, glial cell processes, and the tumor cells kind of circle around those, creating these Homer-Wright rosettes. So that's a classic histologic feature of medulloblastoma, is these Homer-Wright rosettes. The medulloblastoma tumor cells are thought to originate from granule cell precursors in the external germinal layer of the developing cerebellum. And so it makes sense that most of the time they occur in the cerebellum. As we said, typically in the midline posterior fossa, 75% of the time in the midline vermis. Because of their location in the midline vermis, they can often compress the fourth ventricle, which leads to hydrocephalus, and thus they often present with symptoms of increased intracranial pressure. And this is unfortunately a highly malignant tumor, and it does have a tendency to spread via the subarachnoid system. And something that we often see with medulloblastoma is what are called these drop metastases along the spinal cord. So they do need spinal imaging to make sure they don't have these drop metastases from their medulloblastoma. We talked more about the presentation of posterior fossa tumors in our pediatric CNS overview lecture. But just to review, as we said, many of the times these patients will present with increased intracranial pressure, and that's due to compression of the fourth ventricle. So just to review some of the anatomy, recall that the ventricle system in our brain is responsible for producing and circulating our cerebrospinal fluid, and this fluid really cushions our brain as well as our spine. So the start of the fluid is in the lateral ventricles, which drain through the foramen of Monro into the third ventricles, or the third ventricle singular. And then from the third ventricle, the fluid goes through the cerebral aqueduct of Sylvius into the fourth ventricle. And then from the fourth ventricle, it drains laterally through the foramen of Luschka, medially through the foramen of Magendie. So there's a little bit of alliteration there, laterally through Luschka, medially through Magendie. And then from there, it goes to the subarachnoid spaces. So medulloblastomas, which often occur in the vermis of the cerebellum, which is located medially just behind the fourth ventricle, they can push on the fourth ventricle and obstruct the efflux of CSF. That results in raised intracranial pressure. And symptoms of increased ICP include things like headaches, morning emesis, papilledema, diplopia from cranial nerve 6 palsy. And infants who don't have a fully developed skull yet can present with things like bulging anterior fontanelle or splitting of their cranial structures. And then other symptoms of these posterior fossa tumors can include things like truncal ataxia from destruction of the vermis and other cerebellar symptoms such as dysmetria, dysdiadochokinesia, spasticity. And then there are also other possible symptoms such as paranode syndrome, which is upward gaze palsy, and the setting sun sign, which is when patients have this conjugate downward gaze. The paranode syndrome and setting sun sign kind of go hand in hand, and I've included a little picture showing the setting sun sign, which is where the eyes are kind of fixed downwardly and they look like a setting sun. We reviewed the workup of a posterior fossa mass in our introductory Peds CNS lecture as well. But just to review, when patients have a brain tumor seen on imaging in the posterior fossa, the first step is maximal safe resection. So you don't first take them for biopsy and then make a decision on what to do. You typically just take them for surgery up front and do a maximal safe resection. So preoperatively, when they first come in with these neurological symptoms, their workup will typically include a CT head without contrast, an MRI of the brain with and without contrast, and they may or may not get an MRI spine preoperatively, but they typically at least get a CT head and then an MRI of the brain with and without contrast. Then, we see this posterior fossa mass, and the next step is maximal safe resection, which means the surgeons remove as much as they can without causing life-altering deficits. And so if there's a lot of, if it's encroaching on the brainstem or something like that, then they're limited in terms of how much tumor they can safely remove. But they go for maximal safe resection, and then we need to get adequate post-operative imaging. So post-operatively, the brain MRI should be done within 72 hours post-operatively, ideally within 24 to 48 hours post-operatively. And the reason for this is that residual blood products and inflammation around the meninges can become more pronounced beyond 72 hours. So we really want to get a post-operative MRI brain as soon as we can to assess the extent of resection without confounding our imaging with residual blood product that has matured. So MRI brain, ideally within 48 hours, at most within 72 hours after surgery. We also need to get an MRI spine because remember, these tumors do have a propensity for drop metastases. But if we get an MRI spine right away, there can be some confounding artifactual changes in the immediate postoperative period. So the MRI spine we really should get within 14 to 21 days after surgery, not right away. So MRI brain we get right away, MRI spine we wait about 2 weeks. And then these patients should also have a lumbar puncture to evaluate their CSF and see if they have any cancer cells in the CSF. A lumbar puncture can be obtained preoperatively, but if patients have increased intracranial pressure, then there's a risk of herniation. So we typically will actually get this postoperatively. And again, you want to wait about 2 weeks after surgery to avoid any false positives. So at least 10 days, 14 to 21 days is the typical range for postoperative lumbar puncture with cytology. In conjunction, additional labs that we will get are typically, your basic labs like a CMP, and they should have additional workup, including baseline audiometry, neurocognitive and neuropsychiatric testing, neuroendocrine evaluation, and then ophthalmology evaluation. For the workup, it is very, very important to get both the spine MRI as well as the lumbar puncture with CSF cytology. And that's because about 20 to 25% of patients will have leptomeningeal disease at presentation, but a large percentage of them can go undetected with a CSF alone or with MRI spine alone. So around 15% of cases can go undetected if we get just one of the modalities. So we really need to stage them with both an MRI spine as well as an LP. We reviewed this previously as well, but keep in mind that about 2/3 of pediatric CNS tumors are posterior fossa masses, so it's important to keep in mind your differential when a patient comes in with posterior fossa mass. So GAME is a nice mnemonic to summarize the major things on the differential. So it could be a brainstem glioma, astrocytoma, such as a juvenile pilocytic astrocytoma, medulloblastoma, of course, and then ependymoma. So the GAME mnemonic is really nice for your differential for posterior fossa mass. Here are some imaging features of medulloblastoma. So on a T1 MRI, they can appear iso to hypo-intense, and they can have patchy contrast enhancement with this heterogeneous gadolinium uptake, and that can be indicative of necrosis. On T2, the appearance is variable, but they may be iso to hyperintense on flare, and it's very common for them to have surrounding edema. On diffusion-weighted imaging, they tend to appear hyperintense. So whenever we have high signal on diffusion-weighted imaging, that tells us that there is restricted diffusion of our blood due to hypercellularity. So there's basically a mass there that's stopping the normal flow of our blood is how I think about it. So when there's hypercellularity, we get high DWI signal and things appear hyperintense. And then on either CT or MRI, we may see hydrocephalus related to the fourth ventricle obstruction that we discussed. So here's an example case from Radiopedia going through different sequences of the MRI. So on T1 without contrast in the upper left-hand corner of the slide, we see a hypo-intense mass. If you look closely, you can see that it looks darker where there's a mass. The T2 image is showing kind of some heterogeneous intensity, and there is surrounding flare edema. The diffusion-weighted image shows brightness right where the tumor is, so that's hyperintensity that corresponds to the increased cellularity of the mass. And then on the T1 post-contrast, we see a little bit of contrast enhancement, but not like the typical rim-enhancing contrast enhancement that we see with something like a GBM. So this is kind of a more patchy, more subtle contrast enhancement. So we took a look at the preoperative MRI, and then once these patients go for maximal safe resection, we can, look at the tumor under a microscope and get a sense of the histology. So there are 4 major variants to be aware of based on the histology, and these are classic, desmoplastic, nodular, and large cell anaplastic. So anaplastic sounds like what it is, and it's very bad. So large cell anaplastic histology is the least common, accounting for only 5 to 10% of cases, but it does have the worst prognosis and tends to have increased spread through the CSF. So large cell anaplastic is more rare, only 5 to 10%, but then it has the worst prognosis. Classic histology is the most common, accounting for about 80 to 90% of cases. And this has a fairly good to intermediate prognosis. And that's what we see most commonly as classic histology. And then desmoplastic and nodular are, somewhere in between in terms of their incidence. So about 15 to 20% of cases. And these ones tend to have the best prognosis. And these better prognosis histologies like classic, desmoplastic, nodular, they all tend to manifest in older age groups compared to large cell anaplastic, which again, as we said, has the worst prognosis. So the relevance of the histological variants are that we actually use these histological subtypes to divide patients into average versus high-risk medulloblastoma, and that actually impacts their treatment and what fields we treat and what dose we treat to and things like that. So we will talk about this in more detail once we get through staging and risk stratification and get to our treatment paradigm. But just to kind of contextualize why the histology is important, realize that once we do the maximal safe resection, we figure out what the stage of the medulloblastoma is, we incorporate the patient's age, their extent of resection, the stage, and whether they have CSF involvement or spinal metastases and things like that, and also their histology. We incorporate all 4 of those things into their risk stratification. And if patients have large cell or anaplastic histology, they automatically get bumped up into the high risk group, and then they are treated as high risk medulloblastoma. So there's other things that can make you high risk as well, but having large cell or anaplastic histology, which as we said has the worst prognosis, that definitely bumps you up into the high risk group, and then you get treated a little bit more aggressively. So the current standard of care for risk stratifying patients into average risk versus high risk medulloblastoma is to just rely on the histology and then to rely on other clinical factors such as the patient's age, stage, and the extent of resection by the surgeon. So those 4 things are kind of what go into the risk stratification for medulloblastoma, and that's how we determine what treatment to give these patients. And this is the current standard of care, and it really reflects what has been done historically. In the modern era, we do have emerging data that there are certain molecular subtypes that exist within medulloblastoma, and incorporating molecular subtypes into the prognostication may help to actually better divide up these patients, recognizing that some patients have extremely good prognosis and some patients maybe even have worse prognosis than we originally realized. And once we understand that these molecular subtypes are prognostic, the next logical step is to determine, well, are they predictive? Meaning, can we actually alter our therapies based on these subtypes? And so there are ongoing trials to see if we can maybe de-escalate therapy in the Wnt mutated patients, which have the best prognosis and things like that. But this is still kind of in the works, and we don't have clear data that we can do this just yet. The studies are ongoing, but it hasn't changed our standard of care. So as we look at these molecular subtypes, it's important to recognize that they exist, to be familiar with them and understand which ones confer good prognosis versus poor prognosis, and then recognize that there are ongoing efforts to see if we can better tailor our treatments based on these molecular subtypes, but that's not currently the standard of care for patients that are being treated off clinical trial. So the molecular subtypes that we see in medulloblastoma, there's 4 of them. The first one is Wnt, which has a very good prognosis, then sonic hedgehog, which has a good prognosis, group 4, which has intermediate prognosis, and finally group 3, which has the worst prognosis, and it actually tends to be associated with large cell or anaplastic histology. So Wnt is wonderful, it has the best prognosis, and group 3 is threatening because it has the worst prognosis. I literally had to pause my audio so that I could go think of an adjective that started with a TH and meant something bad. So remember, Wnt is wonderful and group 3 is threatening. So 3 has the worst prognosis, Wnt has the best prognosis. And then the other 2 that kind of fall in the middle are SHH and then group 4. So this trend that we're seeing where, historically we just went off of the histology and now we're starting to better classify patients based on the molecular features, this really parallels what we see in a lot of other disease sites, right? Including adult CNS tumors, even endometrial carcinoma, we're kind of seeing the same thing. So this is happening in a lot of other disease sites as well, and medulloblastoma is not unique in that sense. So right now, just realize that we currently risk stratified just based on histology and other clinical features, but coming down the pipeline is probably a change in risk stratification based on molecular subtypes. We just need to kind of follow up on current ongoing studies. Maybe there need to be some new studies, but we need to just confirm that these prognostic molecular subtypes are actually predictive, and we may be able to alter our treatment based on the risk grouping. And then here is just an image showing the age distribution based on molecular subtypes and also how frequent they are. So remember, Wnt is wonderful. It's rarely metastatic, but it's also kind of rare, and it's only 10% of all medulloblastomas. Group 4 and sonic hedgehog, which kind of fall in the middle, make up the majority of medulloblastomas, and then group 3 is still more common than Wnt, accounting for about 25% of medulloblastomas. So group 3 is the one that's most frequently metastatic. Remember, 3 is threatening, Wnt is wonderful, and then I'll leave this here for you to review kind of the different age groups that these tend to affect. So we did share some spoilers related to risk stratification in our background portion of this talk, but now let's formally review kind of the staging for medulloblastoma and then also the risk stratification. The staging system to know for medulloblastoma is something known as the modified Chang staging system. So the Chang staging system was originally published back in 1969, and then it was modified to kind of make it simpler. And what we'd really need to know is this modified Chang staging system. Now, in this system, there's really only two different categories. There's T stage and then there's M stage, which is the degree of metastasis. The T staging is not thought to be very helpful at all, and it really does not guide our management or anything that we do for these patients. It's not thought to be prognostic. So I'm leaving it there for your reference, but keep in mind that we don't really use the T stage when we're staging these patients. What we really rely on is the degree of metastasis, which is known to be prognostic for these patients, and it does go into our risk stratification, and it does affect how we treat these patients. So I'm going to focus on reviewing the degree of metastasis for the modified Chang staging system. So there's M0 all the way up to M4. So M0 means there's no metastases. M1 is if the CSF is positive. M2 is if there is additional intracranial tumor spread beyond the primary site. M3 is if there's gross nodular seeding in the subarachnoid space of the spine. And then M4 is if there are metastases outside of the cerebrospinal axis. So the easiest way to kind of remember these numbers, M0 to M4, is I think to just remember a few of them and then remember whatever else happens kind of falls in between. So I just remember M0, M2, and M4, and then from there I can figure out what M1 and M3 are. So M0 is easy, 0 mets, right? You just have your primary tumor, 0 other mets. M2 is 2 or more sites in the brain. So that's also easy to remember, 2 or more sites in the brain. And then M4 is if you have things outside of the cerebrospinal axis. So that's kind of like what we truly think of as metastasis, right? Where it has spread to a distant site from the primary. So M4 is the most serious, mets outside. M2 is 2 or more things in the brain, and M0 is nothing, no mets. And then M1 and M3 we figure out based on that. So M1 is just if there's CSF, so that's kind of an in-between having nothing at all and having 2 or more sites in the brain. M3 is if there's gross disease in the spine, so the subarachnoid space of the spine. So just remember M0, 2, and 4, and then M1 and 3 you can probably kind of figure out in a test question. The current standard of care, as we said earlier, is to risk stratify patients just based on clinical features such as their age, their extent of resection, their M stage, and then their histology. So this is what you really need to know to risk stratify patients into average or standard risk versus high risk medulloblastoma. And this mode of risk stratification is really what guides our standard of care. So this is the one slide that you really need to know for risk stratification. So remember, there's 4 things that we care about: the age, the extent of resection, the stage, and then the histology. So average risk patients have to be greater than or equal to 3 years. They have to have either a gross total or a near total resection, and that is defined as having less than or equal to 1.5 centimeters squared residual tumor, so less than or equal to 1.5 centimeters of residual tumor. And then M stage, they have to be M0 by both MRI and CSF, because remember, about 25% of patients have metastatic disease, but in order to be average risk, they have to be M0 by both modes of staging, so MRI and lumbar puncture. And then the histology, they just can't have large cell or anaplastic histology. Any of the other ones are fine. If they meet all of those criteria, then they are considered average or standard risk. If they have any high risk features, that bumps them up into the high risk category. So less than 3 years, subtotal resection defined as greater than 1.5 centimeters squared of residual tumor. If they have any degree of metastatic disease, including positive CSF, gross metastases, or leptomeningeal seeding, and then if they have large cell or anaplastic histology. So any of those features would make them high risk, and then if they meet all of the average risk criteria, then they are considered average risk. And this is the classic risk stratification that you need to know, and this is kind of what determines our current standard of care off clinical trial. If we look at most of the clinical data that we have from the past 20 years for non-infants, so any children that are over 3 years old that have been treated with upfront chemo and CSI, all of these trials have risk stratified patients just based on those clinical criteria that we just went over. And what they find is that for patients that have an average risk medulloblastoma, the 5-year expected survival is over 80%. And then for patients that have high risk medulloblastoma, the 5-year survival is on the order of about 60%. So these patients do, relatively well. So it is important to, keep in mind the long-term toxicities and things like that when we're treating these patients. They do perform relatively well. And that's why, proton therapy, whenever possible, is very important. As we discussed before in the overview lecture, proton therapy has been associated with improved neurocognitive outcomes in these patients. So we definitely want to keep in mind that they do have high long-term survival. So those are kind of the numbers for medulloblastoma patients that have been risk stratified according to these classic criteria. As we said early, we are now recognizing more molecular subtypes, and our newer generation of clinical trials is working to evaluate things like de-escalation for Wnt tumors, which have much better prognosis and things like that. But standardly, the things that we know are associated with a bad prognosis: age less than 3, any degree of metastases, subtotal resection, and subtotal resection can happen when there's brainstem involvement because they're not able to get all the tumor out, anaplastic and large cell histology. And now we're trying to see if we should be adding group 3 or group 4 molecular profile based on the MYC or MYC-N amplification into that box of what confers a worse prognosis, and if we should be changing our treatment based on that. So here's a proposed molecular-based risk stratification, which is kind of being used to shape future clinical trials and even ongoing clinical trials right now. So you'll see that they have not just average risk and high risk, but in addition to that, there's also a low risk and then a very high risk. So low risk is patients that have Wnt molecular subgroup, and then very high risk is patients that have metastatic group 3 and SHH with TP53 mutations. So these are kind of very high risk. And you'll see that the survival is kind of broken up even more. So it's not just more than 80% average risk versus around 60% for high risk. It's, over 90% survival for these low risk Wnt subgroup patients, 75 to 90% for average risk patients, 50 to 70 for high risk patients that have either metastatic, MYC-N amplified SHH or group 4, and then less than 50% for the very high risk, which are metastatic group 3 and SHH with TP53 mutations. So we don't have to memorize all of these different risk groups, but just recognize that we are now trying to use the molecular data that we have to even further subdivide the risk stratification from beyond just average versus high risk, now adding on low risk as well as very high risk, recognizing that the expected survival of these patients is vastly different. And then we're trying to apply this clinically in ongoing trials, looking at either de-escalation for our low-risk patients or perhaps even escalation for high and very high-risk patients. So this is kind of future directions. Recognize that the current standard of care is just based on average risk versus high risk, but this will probably change in the future. I'm not going to go too much into detail on this SJMB03 study that I have here, but this is basically a study that performed DNA methylation and next-gen sequencing analysis to identify kind of new clinical molecular risk factors, and they identified additional kind of mutations within the previously defined molecular subgroups, which can help kind of further elucidate whether patients fall into low risk versus higher risk groups. And so this study is another kind of contributor to the data that we have identifying potential risk stratification to help guide future trials. But just for the sake of simplicity, I want to pop this slide back in here and just highlight that the classic risk stratification is where we are currently and kind of what you need to know to guide your standard of care treatment off of a clinical trial. So age over 3, so 3 or more years old, gross total or near total resection, having M0 stage by both MRI and CSF, and then any histology other than large cell or anaplastic. Those are what make you average risk. And if you have any of those high risk factors, then that bumps you up into the high risk group. And that brings us to our treatment paradigm. So the first step in management, as we have said, is maximal safe resection. And our aim is always to get out as much tumor as we possibly can, aiming for either a gross total resection or at least a near total resection where there's less than 1.5 centimeters squared residual disease. Now, we have to understand, though, that if the tumor is invading into a critical structure such as the brainstem, then the surgeon can't remove that without, compromising the patient's life potentially. And so we obviously don't then resect into the brainstem. And then those are kind of the patients that are left at higher risk because they have a subtotal resection. So we aim for gross total or near total resection whenever possible. And this is very much determined by the location of the tumor. After maximal safe resection is complete, we need to make sure that we finish up all of the workup that we need to determine the stage and risk group of these patients. So that involves getting a postoperative brain MRI, ideally 24 to 48 hours after surgery, at most within 72 hours, an MRI of the spine, and this should be done about 10 to 14 days postoperatively. We don't want to get it too soon to avoid artifactual confounding. And then an LP post-op as well, and we typically get this also 10 to 14 days post-op. So brain imaging we get right away, spine, LP, as well as the MRI we get later. Then we have to kind of, based on the staging and risk stratification, determine our adjuvant treatment. And adjuvant treatment typically involves a combination of both radiation and chemotherapy. So because medulloblastoma has such a high propensity for drop metastases to the spine, all of these patients are treated with craniospinal irradiation. And the dose of craniospinal irradiation is based on the risk. So average risk patients are treated with 23.4 gray at 1.8 gray per fraction. And high risk patients are treated at least 36 gray at 1.8 gray per fraction. But if they have disseminated spinal metastasis, then we increase that to 39.6 gray. So the dose really depends on the risk. So average risk, remember 23.4 gray. High risk, it's 36 gray. And then we boost the tumor bed. So for average risk patients, it really is just a tumor bed boost. And we do this to a dose of 54 gray for average risk patients. For high-risk patients, we actually boost the entire posterior fossa, and we take it to a slightly higher dose of 55.8 gray, so one additional fraction for those high-risk patients. This is typically started about 1 month post-operatively, and we try to complete all of the radiation within 45 days because we know that total treatment time matters, and for patients that take longer than 45 days to finish their radiation, they actually have worse outcomes. So we try to finish the radiation quickly once we're started. And then the chemotherapy. So typically radiation is given with concurrent weekly vincristine, although this is institution dependent and not all institutions do give concurrent chemotherapy, but the standard is usually radiation with concurrent weekly vincristine. And then after they're done with the radiation and the concurrent chemo, they get additional adjuvant cisplatin-based chemotherapy for up to 9 cycles. So it's very intense treatment, right? Maximal safe resection, you finish up their staging for the brain and the spine, and then they get CSI with chemoradiation, and then they get further adjuvant chemotherapy, and it's a very, very intense treatment. Now, keep in mind that radiation with CSI is really reserved for patients that are over 3 years old. For children that are younger than 3 years old, we really try to avoid craniospinal irradiation at all costs. And there is data that suggests that the older that children are at the time that they get CSI, the less sort of neurocognitively debilitating the treatment is. And especially for children that are less than 3 years old, the CSI causes so much damage to their developing brain cells, and they are rendered so kind of disabled from the treatment that we really feel that the risk kind of outweighs any benefit that the CSI provides. So for children that are younger than 3 years old, we actually prefer delaying CSI with intensive chemotherapy. And there's something known as the Head Start protocol that these children might be enrolled on, where they may or may not get focal radiation, but the strategy is really to pursue intensive chemotherapy and try to delay CSI as much as possible for patients that are younger than 3 years old. But for older patients over 3 years old, the treatment is kind of as I outlined, where they get maximal safe resection and then finish their workup, and they get craniospinal irradiation plus a boost with concurrent and adjuvant chemotherapy. Getting into more details then about the surgery, radiation, and chemotherapy, starting with principles of surgery. So as we said, the first step in management for these patients is maximal safe resection with an aim for gross total or near total resection. So gross total resection means they remove all of the disease. Near total resection is defined as less than or equal to 1.5 centimeters square residual diameter, or over 90% resection. That threshold of 1.5 centimeters squared is something that was defined back in the 1980s, and it continues to be used to this day. And it is thought that gross total and near total resection are no different in terms of their prognosis. So they really have kind of an equal prognosis. So that is why they are both, whether you have gross total or near total, it counts as average risk medulloblastoma. Now, subtotal resection is if there is 51 to 90% resection. Partial resection is if there's 11 to 50% removal, and then a biopsy is if only less than 10% of the tissue was removed. So subtotal, partial resection, and biopsy mean that there is a great amount of residual tissue left, and that then puts patients in the high risk group. So gross total and near total, again, are the goal. Now, when patients undergo surgery to the posterior fossa, they may sometimes develop what is known as postoperative posterior fossa syndrome. So posterior fossa syndrome can be a complication from surgery in up to about 25% of patients, and it is defined as a cerebellar mutism. The symptoms, there's a nice mnemonic known as SAME, S-A-M-E, that goes over all of the symptoms of cerebellar mutism. So there can be swallowing dysfunction, truncal ataxia, mutism, and emotional liability. It's just important to kind of memorize that mnemonic and understand what posterior fossa syndrome is. This typically occurs around 12 to 24 hours postoperatively, and then it self-resolves over a period of weeks to months. The important thing to realize is that if patients have symptoms of posterior fossa syndrome, this should not delay their adjuvant treatment, and they should still go on to get adjuvant treatment as planned. After surgery, remember, we try to start radiation within about a month after surgery. And on this slide, I've tried to outline the relevant dosing information that we need to know. So we typically do craniospinal irradiation as well as a boost. So craniospinal irradiation dosing is at 1.8 gray per fraction. Actually, all of this is at 1.8 gray per fraction. And with craniospinal irradiation, if it's an average risk patient, the CSI dose is 23.4 gray, and then we boost the tumor bed to a total of 54 gray. If it's a high risk patient, the dose is 36 gray for CSI, and then we boost the posterior fossa to 55.8 gray. So remember that not only is the dosing different for high risk, but the volume is different as well. So it's only a tumor bed boost if they are average risk, but then if they are high risk, we boost the entire posterior fossa. And then finally, if they have diffuse spinal cord involvement, we can take the entire CSI dose to 39.6 gray, or kind of the entire spine dose to 39.6 gray. And then if they just have metastases within the spine, we can do the 36 gray high risk dose and then boost the spinal metastases. If it's within the cord, we would do 45 gray. If it's below the cord, we can safely dose escalate a little bit up to 50.4 gray. So increased dosing depending on if there's spinal metastases, but the most important doses we need to memorize here are the average risk and high risk CSI doses, and then the tumor bed boost for average risk is 54 gray, and the posterior fossa boost for high risk is 55.8 gray. I have some more details on radiotherapy planning for average versus high risk patients. So starting with the average risk patients, this is as per ACNS 0331, which is a study from the COG, or the Children's Oncology Group, that specifically looked at average risk medulloblastoma. So remember, first we do CSI for a total of 23.4 gray. And on this protocol, the patients did get concurrent chemotherapy. And that's actually an important note because the dose of 23.4 gray CSI is actually a reduced dose from the old standard, which was 36 gray, and it's only been studied in the setting of concurrent chemotherapy. So if we are going to decrease the dose to 23.4 gray, it's very important that the patients do get chemotherapy. But anyway, the CSI CTV includes the whole brain as well as the spine. And for more details on CSI planning technique, I would recommend you watch the overview video where we spend the entire second half of that video talking about the CSI technique. But typically our volume encompasses the whole brain and the entire thecal sac, and inferiorly it goes down to S2, S4, which is where the thecal sac ends. Subsequently, after the CSI portion, we go on to provide a tumor bed boost, which is also known as involved field radiation. So we used to actually boost the entire posterior fossa for these patients, but then the ACNS 0331 study told us that doing just a tumor bed boost for average risk patients is non-inferior. So we then go on and boost the tumor bed for a total of 54 gray. And the tumor bed is defined as the resection cavity along with any gross residual tumor, plus a 1.5 centimeter margin for CTV, and then a 3 to 5 millimeter margin for PTV. So keep in mind that all of these doses are prescribed at 1.8 gray per fraction. So it's 13 fractions for the CSI portion. And then by the time we get to 54 gray, it's 30 fractions total. So it's 17 fractions of boost. So 23.4 gray and 13 fractions, and then they get an additional 17 fractions for just the boost volume to get up to 54 gray. But it's all done at 1.8 gray per fraction, and the boost is given sequentially. And then there is one dose constraint that I'll point out, which was mentioned in their protocol, which is that the cervical spinal cord between C1 to C2, no more than 50% of the spinal cord should receive more than 54 gray, or 54 gray or more of dose. So the V54 gray should be less than or equal to 50% for C1 to C2. And then here are further radiation details for the high-risk patients. So remember that for these patients, the CSI dose is bumped up to 36 gray. So we are now giving them 36 gray and 20 fractions for their CSI dose. And then their posterior fossa boost, so in average risk, we were just boosting the tumor bed, which was involved field radiation. For high-risk patients, we are boosting the entire posterior fossa, and we're doing that in we're giving them a total of 31 fractions. So they're getting an additional 11 treatments after their CSI for 20 fractions to get a total of 55.8 gray at 1.8 gray per fraction. And the borders of the posterior fossa are written here. So your CTV goes to the tentorium cerebelli superiorly, anteriorly to the anterior border of the brainstem, inferiorly to the bottom of the C1 vertebral canal, so the C1, C2 junction, and then the bony walls of the skull laterally. And then we add an additional 3 to 5 millimeters on the posterior fossa and boost all of that to 55.8 gray. And then keep in mind, if patients do have kind of gross metastases in the spine, we need to give them an additional boost. So if they have diffuse spinal mets, then the CSI dose just increases to 39.6 gray. But if they have focal mets, we can treat them to either 45 gray or 50.4 gray, depending on where they are in relation to the cord. And then in terms of chemotherapy, so the standard concurrent chemotherapy is weekly vincristine with radiation. And there is a high-risk ACNS protocol that recommends doing concurrent vincristine with carboplatin for high-risk group 3 medulloblastoma. And we try to begin chemoradiation within 1 month or within 31 days of surgery. And remember that the dose reduction of CSI, so where we give 23.4 gray for average risk patients, is really only possible when it's given with concurrent chemotherapy. So if there is a patient that cannot get chemotherapy for some reason and they're average risk, then they still have to go to the full 36 gray CSI dose. The dose reduction has only been investigated in the setting of concurrent chemotherapy. So the only time that we can go down to 23.4 gray for CSI is if these patients are getting concurrent chemotherapy. Then after they complete the concurrent chemotherapy portion, they move on to get their adjuvant kind of maintenance chemotherapy. And this is a maintenance cisplatin-based chemotherapy. So in the average risk ACNS 0331 study, they began 4 weeks after the completion of chemoradiation, and then cycle A consisted of cisplatin, CCNU, vincristine, and cycle B was cyclophosphamide with vincristine. And they alternated kind of cycle A versus cycle B. In the high-risk protocol, ACNS 0332, they got maintenance vincristine, cisplatin, and cyclophosphamide every 28 days for 6 cycles. So there are different chemotherapy protocols, but they generally incorporate cisplatin and vincristine, and this is given in the maintenance setting for up to 9 cycles. If you'd like to take a break now, this might be a good time because I recognize this has been going for a very long time. I am going to keep powering through and go through the evidence, but we're not going to cover too many trials here. So what I have found in the practice questions that I've done is that for pediatric cancer, more than sort of rigorously testing the evidence the way they do for a lot of adult cancer sites, I feel that they focus really more on kind of the standard of care paradigm and workup and things like that. So it's much more clinically oriented, is at least what I have found. And I have a really hard time kind of keeping track and making sense of all of these, pediatric cancer trials. So what I've tried to do is just pull out some of the most important risk-adapted treatment protocols, and we're only going to go through 3 different trials, but these are all trials that kind of give us justification for the treatment paradigms that I just went over. So I'm really trying to keep it kind of clinically relevant and not go into excruciating details in the evidence base. The 3 trials that I'm going to present are ACNS 0331, 0332, and then 1442. The ACNS is the American Clinical Neurophysiology Society, and these trials are COG trials, so they are from the Children's Oncology group, but they're done in collaboration with the ACNS group. So they're all called ACNS trials, and keep in mind that they're done in collaboration with COG. So the first trial, ACNS 0331, is a phase 3 trial that's specifically geared towards average risk patients. And this trial asked 2 different questions. Number 1, they asked in average risk patients when we're giving CSI with concurrent chemotherapy, can we decrease the dose from 23.4 gray down to 18 gray for CSI in patients that are aged 3 to 7, in the hopes of mitigating some of the toxicity from CSI by decreasing that dose. And then the second question was, can we get away with a tumor bed boost rather than a posterior fossa boost for these average risk patients? And they included all children ages, so 3 to 21 for that question. So based on the treatment paradigm that we just went over, you can probably glean that the answer to the first question was no, and they actually had worse outcomes with reduced dose CSI. So 18 gray did worse than 23.4 gray, and that's why 23.4 gray, when we're giving concurrent chemotherapy, remains the standard, even for patients ages 3 to 7. But then the answer to the tumor bed boost question was yes, because that is the standard now, is to boost the tumor bed only for average risk patients rather than the entire posterior fossa. So we'll first go through ACNS 0331, then we'll go through 0332, which looked at concurrent carboplatin with or without maintenance isotretinoin to improve outcomes for high-risk patients. And then finally, we'll mention 1442, which is a de-escalation study for average risk Wnt subtype, which we are trying to elucidate whether that average risk Wnt subtype can truly be kind of separated from the others as a low risk group. So let's start with ACNS 0331. 0331, as we just said, asked two questions about average risk medulloblastoma patients. So they enrolled patients with average risk medulloblastoma that were aged 3 to 21 who had undergone either a gross total or near total resection, which remember is part of the criteria to be considered average risk. They excluded anyone with anaplastic histology or disseminated risk. Again, all criteria that make you average risk. And then the two questions that they asked were as follows. Number one, for children that are aged 3 to 7, can we consider reducing the CSI dose from 23.4 gray down to 18 gray? And then for all patients that they enrolled, ages 3 to 21, can we reduce the radiation field so that instead of boosting the entire posterior fossa, we are just boosting the involved field, so the tumor bed? The answer to that second question about the boost field was yes, right? Yes, we can reduce the field that we do, and that is now reflected in our standard of care. So when they compared involved field radiation versus posterior fossa radiation, they found no significant difference in event-free survival or overall survival with the reduced boost volume. So the EFS was 83% versus 81%, not statistically different. And the overall survival was just about 85% in both arms. So EFS and OS both in the mid-80s, excellent outcomes with the reduced field boost volume. So now we know that for average risk medulloblastoma, instead of boosting the entire posterior fossa, we can safely reduce that field to just the involved field without compromising outcomes. That first question, however, on reducing the dose for CSI for patients aged 3 to 7, that answer was a no. So what they found is that EFS and OS were actually significantly worse with the low dose CSI compared to standard dose CSI for those patients ages 3 to 7. So the EFS was 71% with 18 gray, and then it was 83% with 23.4 gray. So that was about a 12% difference in EFS, statistically significant. And similarly, there was about a 9% difference in overall survival. So overall survival went from 78% with 18 gray up to 87% with 23.4 gray. So significantly worse outcomes with low dose CSI, and therefore 23.4 gray for CSI remains standard when we're giving concurrent chemotherapy for patients with average risk medulloblastoma, even if they are aged 3 to 7. The impetus for that question came from some data that for children that are 8 years or older, when they get CSI, they have worse kind of neurocognitive defects related to the CSI treatment. So for those younger patients that kind of tend to have worse neurocognitive outcomes, can we try to decrease the dose so that they don't have as much toxicity? But unfortunately, the answer to this question was negative. When they looked at the results in this study based on molecular group, they did see some interesting results. So for one, they found no significant difference in the event-free survival for IFRT versus PFRT based on the WNT group 3 or group 4. But in the sonic hedgehog subgroup, the patients that got involved field radiation as opposed to posterior fossa boost actually had improved event-free survival. So it went from 75% with the posterior fossa boost up to 91% with the involved field radiation boost. And it's conceivable, I'm not exactly sure why this is, but it could be related to the occurrence of secondary malignant neoplasms. These were really only seen in the SHH patients that got posterior fossa radiation, and it's perhaps conceivable that the larger volume that was radiated, the higher doses in these patients, perhaps contributed to the development of secondary malignant neoplasms. So perhaps that went into the increased EFS for the SHH patients. The other kind of molecular-based outcome that they found is that there were worse outcomes in the low-dose CSI group, and these were primarily driven by the group 4 patients. So if you look just at group 4, the EFS was 77% with the low-dose CSI, so 18 gray, and it was improved to 97% with the 23.4 gray. And then they also had a nice image in their paper looking at different patterns of failure. So you can see in the WNT group, the predominant 100% of the failures were all local. And then as we go from SHH to group 3 to group 4, we start to see more distant failures. So just to summarize the major outcomes from ACNS 0331, can we reduce the volume of boost for average risk medulloblastoma? The answer is yes, we can get away with a tumor bed boost or involved field radiation as opposed to boosting the entire posterior fossa. Can we reduce the CSI dose for patients aged 3 to 7 with average risk medulloblastoma? And the answer to this, unfortunately, is no, because we saw significantly worse event-free survival and overall survival on the order of 7 to 10% with the 18 gray dose compared to the standard 23.4 gray dose. And what are the differences in toxicities? So they found no significant difference in IQ between the posterior fossa boost and the involved field radiation, but they did see greater decline in IQ for patients aged 3 to 7 with the standard dose CSI compared to the lower dose CSI. It's possible that modern radiation techniques, and we've talked about in the overview lecture the data for protons, but modern techniques may be associated with less global cognitive morbidity for older children that are 8 years and older. Moving on then to our trial for high-risk medulloblastoma patients, which is ACNS 0332. So this trial asked, does it benefit to add concurrent carboplatin during radiation or add isotretinoin during maintenance chemotherapy for children with high-risk medulloblastoma? And so this trial enrolled patients with high-risk disease, ages 3 to 21, that had either metastatic disease, anaplastic histology, and or incomplete resection. All of these patients were treated with 36 gray CSI, followed by 55.8 gray total posterior fossa boost. The radiation was started within 31 days of surgery, and they all received maintenance therapy with vincristine, cisplatin, and cyclophosphamide every 28 days for 6 cycles. The randomization was first to concurrent vincristine with or without concurrent carboplatin during the radiation. And then during maintenance chemotherapy, they were randomized to chemotherapy with or without isotretinoin for 12 cycles. So they ended up having 4 different arms as shown in this flow diagram. Now, the isotretinoin arms closed early due to futility, and so the study ended up just becoming about whether or not we should add concurrent carboplatin for high-risk patients during radiation. What they found is that overall, there was no significant event-free survival or overall survival benefit for the concurrent carboplatin added to the chemoradiation with standard vincristine. However, when they stratified patients based on their subgroup, they found that for group 3 patients, so group 3 molecular subgroup, there was a significant benefit with the addition of carboplatin. So if you look across the board, the EFS was 60% versus 66%. The overall survival was not statistically different, although it was 70% versus 78% with the carboplatin. Those outcomes did not meet statistical significance. But when they looked just at the group 3 patients, the EFS was 65% with the addition of carboplatin versus only 40% without carboplatin. So the conclusion from 0332 was that concurrent carboplatin treatment during radiation is recommended for patients with high-risk group 3 medulloblastoma. The last trial I want to bring your attention to is ACNS 1442, which is an ongoing phase 2 trial investigating de-escalation of therapy for low-risk medulloblastoma patients. So low-risk medulloblastoma is not a current subgroup that we standardly think about, but because we know that Wnt-driven medulloblastoma has such a better prognosis compared to the others, we are trying to see if we can de-escalate therapy for these patients. Can we think about them as low-risk medulloblastoma and truly de-escalate therapy for these patients? So there are 3 key differences in therapy for these patients compared to what they would get if they were otherwise just on an average risk trial or average risk course of treatment. So what are these differences? Number 1, they are reducing the CSI dose to 18 gray instead of the standard of 23.4 gray. Number 2, they are not giving any concurrent vincristine with the radiation, so no concurrent chemo with the radiation. And then number 3, they are reducing the number of cycles of the maintenance chemo regimen from 9 cycles every 28 days down to 7 cycles. So they're still doing a cycle A, cycle B approach, but they're doing only 7 total cycles instead of 9. So the 3 differences are number 1, reducing the CSI dose to 18 gray. Number 2, getting rid of the concurrent vincristine with radiation, so it's just radiation on its own. And number 3, decreasing the total number of maintenance chemotherapy cycles. So it'll be interesting to see the results of this, and probably in the future, the way that we risk stratify medulloblastoma will kind of more reflect those clinical molecular risk groups rather than just what we have with the clinical risk stratification. So just to wrap up, here is a quick summary of management for medulloblastoma. Remember that patients typically present with posterior fossa tumors, and the first step in their management is maximal safe resection. About a month after, they are started on concurrent chemoradiation. So it's CSI with a boost, and they're given concurrent vincristine. The CSI dose is 23.4 gray for average risk, assuming they get concurrent chemo, or 36 gray for high-risk patients. If they have disseminated spinal disease, then it's 39.6 gray CSI. The boost volume depends on the risk stratification. So if they are average risk, they just get a boost to the tumor bed. If they are high risk, it's the entire posterior fossa that's boosted. And the dose is different depending on the risk as well. So average risk, it's a tumor bed boost to 54 gray. High risk, it's a posterior fossa boost to 55.8 gray. And then if they do have spinal metastases, we can treat those to 45 to 50.4 gray. And after they complete chemoradiation, after another about month of rest, they get started on their maintenance chemotherapy, which often incorporates cisplatin as well as vincristine. So that is all I have for medulloblastoma. Hopefully this presentation helped to demystify this disease a little bit. I think the biggest takeaways here are that medulloblastoma has a very high risk of spine metastases, and so that is why we treat all patients after surgery with craniospinal irradiation, because there's that high risk of spinal drop metastases. And then the other big takeaway is just the risk stratification, and keeping in mind that right now we risk stratify really just based on the clinical features, so the age, stage, histology, and extent of resection. But probably coming down the pipeline is a revised risk stratification system that incorporates their molecular subgroups as well. We're just not at that point yet, and we need to kind of wait for some ongoing studies to mature before we can make these revisions. So for right now, it's a little bit easier, I think, and it's just average versus high risk based on clinical features. So thank you so much for your time and attention.